Hello, everyone. Welcome to this webinar on ASH 2024 myeloma and AL amyloidosis highlights that Myeloma Patients Europe has organized. I'm Solène Clavreul, Head of Medical Education and Scientific Engagement at MPE, and I will be the moderator of this webinar. Next slide, please. We will start with a short introduction and housekeeping rules, and then our speaker, Dr. Charlotte Pawlyn, will present her myeloma and AL amyloidosis highlights from ASH 2024, and we will then continue with a question and answer session before closing the webinar at 6 p.m. Paris time. So next slide, please. First, I would like to give a short reminder on how to use the Zoom webinar app. So attendees are not seen or heard in a webinar, so you should be able to see and hear the presenters, but you will not be able to see or hear other attendees, and they will not be able to see or hear you. That's normal. If you cannot hear the presenters, make sure that your speakers are not muted and that the volume is set high. You can watch the webinar in gallery view. Those settings enables you to see all the presenters in a tiled format on your screen, and the view setting can be changed on the upper right corner of your screen. You can toggle back and forth between gallery view and speaker view if you want. Use the question and answer or Q&A feature, which is found on the toolbar at the bottom of the window. Please use this feature to ask a question to our panelists and click on the like button to upvote a question to let us know what questions are of high interest to you. And please don't wait until the end to ask your questions, as we will try to group them by topic while the presentation is ongoing. So we are ready to move forward when the presentation ends. Next slide, please. There's also a chat feature, so please use that one to chat with other participants, share your experience or comments on the current discussion. You can consider audio only mode if you are having troubles with poor video or if the signal is cutting in and or out, and consider attending in audio mode and bypassing the video in that case. If you are experiencing any technical issue, please let us know about it here in the chat or via email, and one of my colleagues will assist you. Don't use the chat to ask questions to the presenters, but rather use the Q&A feature for that purpose, and use the chat for to talk to other participants. Next slide, please. One last thing. If you don't see the toolbar at the bottom or at the top of the Zoom window, move your mouse slightly and the bar will appear, and this bar will disappear after a few seconds when you are in full screen mode. The webinar is being recorded and will be available on our website, www.mpeurope.org, and on our social media channels. One last thing, the webinar is intended to provide general information on and discuss clinical research results that have been presented at ASH this year, not to provide personalized or individual medical advice. So please consider this when sending us your questions. So now let's talk about ASH. So the American Society of Hematology, or ASH, is a professional organization representing hematologists that was founded in the late 50s. And this annual meeting is held every year and attracts more than 30,000 attendees. It's a 4-day meetings with several educational programs, lectures, symposia, and scientific sessions being held. And it also features oral and poster presentations containing developments in scientific research. The 2024 annual Congress was the 66th one, and it was held at the beginning of December in San Diego in the United States. And we have organized this webinar to share with you the highlights of the conference, and so you can ask questions related to the latest results in the myeloma and the AL amyloidosis fields. Next slide, please. So I'm very, very pleased to present and welcome our speaker of the day, Dr. Charlotte Pawlyn. Um, and I will briefly introducing her before letting her the floor. So Dr. Charlotte Pawlyn is a team leader at the Institute of Cancer Research and an honorary consultant hematologist at the Royal Marsden Hospital in London, United Kingdom. Her current research focuses on identifying therapeutic targets for patients with immunomodulatory drug resistant and high-risk myeloma. And in addition to her laboratory work, Dr. Pawlyn works in clinical trials as part of the UK Myeloma Research Alliance, and she has contributed to a large number of national frontline studies and international studies as well. She has strong expertise in clinical research and a deep knowledge in the field of myeloma, and her research work has been published in multiple scientific papers in top journals in the field. And she's also a member of the research advisory group of our member in the UK, Myeloma UK, and a member of Myeloma Patients Europe Medical Advisory Committees as well. So thank you so much, Dr. Pawlyn, for being here with us today and for dedicating some of your precious time to MPE to share your highlights from ASH. So thank you so much, and the floor is yours.
Thank you for inviting me, and thank you to everyone who's joined this afternoon. I'm just going to share my slides. So then, can you see those okay?
It seems to work perfectly.
Excellent. Perfect. So again, thank you for inviting me. I'm going to give you some of my key updates, I guess, from going to the ASH meeting this year. I guess before I do that, I want to say a few things. One, these are my initial thoughts. So I came back from ASH at the end of last week. So there's little time to have digested information. And I think information, when you're in information overload in some of these meetings, sometimes needs a little bit more time to digest when you're not jet lagged. And so I reserve the right to change my opinion on some bits of data as I read more or hear more or listen to more outcomes from the studies. And I also want to apologise if I've missed some important studies. So perhaps those that you might be taking part of, or members of your organisations might be taking part of, that are run in your country, or that are run by the doctors who look after you or your members. And so I want to say I cannot possibly cover all that was presented at ASH. There was lots of really exciting data, and I've done my best to try and distill out some key bits to share with you today. I also want to thank some of the authors of the work that I'm going to present, who kindly shared their slides with me so that I could make sure what I was presenting and discussing with you today was as accurate as possible, and in some places cropped pictures from those to share with you and show you that data that was presented. So on this slide, I'm just outlining what I will talk about. So we're going to go through some studies for patients with newly diagnosed myeloma, then look at some studies for patients with relapsed myeloma, particularly focusing on new drugs or treatment approaches that I can see on the horizon that I thought had exciting or interesting data that was presented this year. I'm going to cover some studies on amyloid, and then also some studies on smoldering myeloma, or the precursor condition that can occur before patients are diagnosed with myeloma. So we're going to launch straight in and think about newly diagnosed myeloma patients, and start by thinking about studies that really looked at younger patients with myeloma. And by that, we usually mean patients who are considered to be suitable for an autologous stem cell transplant approach. And this was an interesting update of a study led by the German group, looking at combining the anti-CD38 antibody isatuximab to the combination of bortezomib, lenalidomide, and dexamethasone for newly diagnosed myeloma patients. So if you look at the bottom of this slide, this helps to outline the study, and I've tried to simplify it as much as possible. So patients were randomized between having just lenalidomide, bortezomib, and dexamethasone, or the addition of isatuximab to that combination before going on to have an autologous stem cell transplant. The study has a few more questions that it is addressing than this, but this was the portion of the study that they presented data for at the meeting. In total, there are 662 patients who were included in this study, and all patients had newly diagnosed myeloma and were considered suitable for going on to an autologous stem cell transplant, which is usually younger and fitter myeloma patients. And then they were randomized in this fashion. What I'm showing here is the data that was presented by the authors at the meeting. So what you can see here is a graph that looks at the time from when patients are randomized into the study, which is similar to when they're first diagnosed, but usually maybe a short while afterwards. And from that time of randomization until patients experience disease progression. So that shows the purple curve here, shows the patients who received isatuximab, the anti-CD38 antibody, in addition to the backbone treatment. And you can see that they found that patients who had that addition of isatuximab remained in remission for longer than those who did not, which is shown in the green curve. And they did some statistical tests to show that that was significantly prolonged. It's hard to get full numbers in terms of average times that patients were in remission, because actually, despite having followed up the patients for a long time, they haven't reached the point where the average patient has yet progressed. And so they don't have that data, but they can already at this point show that there is a benefit from adding isatuximab into that combination for newly diagnosed patients. And that's also summarized in the graph at the bottom, on the bottom right here, where you can see that patients who had the addition of the isatuximab in the purple bar, there were more patients who had the very deepest possible response to treatment, called minimal residual disease negative, at the end of their induction therapy than for those patients who just had the triplet. So more patients were achieving that really deepest response with the addition of isatuximab to that combination. So the authors concluded that adding in the isatuximab, which was given for about 18 weeks during induction, so it was just given before the stem cell transplant, so not for, in this portion, they were just looking at that addition at the beginning, that reduced the risk of progression or death for patients who had that added and led to deeper responses. So my take on this, I guess, is this is quite consistent with other studies of other anti-CD38 antibodies that we've seen over time. This addition of an anti-CD38 antibody to initial treatment regimens seems to improve outcomes, deepen responses. And in countries where this is reimbursed, it's now considered standard of care to add in that anti-CD38 antibody to the initial treatment for patients. So moving away from the younger patients to the older patient group, there were some really interesting studies presented for older patients at ASH this year, which is perhaps a group of patients who've been less well studied in trials in the past. And this is one of them. This is a French study that looked at the combination, if you look again at the bottom of my slide, the combination of daratumumab with lenalidomide compared to the combination of lenalidomide with dexamethasone. And importantly, in this left-hand side here with the daratumumab and lenalidomide, patients only had dexamethasone, the steroid tablet, for the first 2 months of their treatment. And so the authors were comparing this combination of daratumumab lenalidomide to lenalidomide with the steroid. And the reason for doing that was because we've seen in previous studies that frailer, older patients often experience more side effects of treatment. And some of these are driven by the steroid dexamethasone, which is given in lots of treatment combinations. And so they aimed to study whether the combination of Daralem without dexamethasone was still associated with better outcomes than lenalidomide and dexamethasone on its own. And the reason for saying still associated is because there has been a previous trial looking at the combination of daratumumab, lenalidomide, and dexamethasone compared to lenalidomide and dexamethasone. And that found that with dexamethasone in that combination with Dara and Len, there were improved outcomes for patients. So this was really just looking at whether that remained true if you took the dexamethasone away from that combination. So in this study, almost 300 patients were included, and really impressively, over almost 2/3 of patients were over the age of 80. And that really represents a unique thing for myeloma trials to try and recruit this older, frailer group of patients. Patients had to be newly diagnosed with myeloma and classified as frail based on an assessment of a combination of age and comorbidities of patients and physical functioning. And then patients were randomized in the way you can see at the bottom. And what the authors found was that the patients receiving daratumumab and lenalidomide remained in remission for 53 months on average, compared to 23 months on average for patients who received the lenalidomide and dexamethasone combination. So essentially showing that even without dexamethasone, the daratumumab lenalidomide combination, it does seem to be associated with longer time to progression than lenalidomide and dexamethasone on its own. They did find that patients having the daratumumab in the mix were slightly more likely to have low blood counts, but there wasn't any difference in the number of infections that patients experienced. There didn't, surprisingly to me, slightly seem to be a significant difference in quality of life in the way that they presented it at the meeting between the two groups, but that's something they're potentially going to look at in more detail. This was a very overall look at quality of life between the groups of patients. So they concluded that the dara-len combination was associated with a significant reduction in the risk of progression or death in newly diagnosed frail myeloma patients compared to lenalidomide and dexamethasone alone. So my take on this is really important data in a large group of older and frail myeloma patients, and it's kind of reassuring to us. We are inclined to want to stop dexamethasone for patients because it does cause a lot of side effects, but it's useful to have this data to show that even without the dexamethasone, this combination is still leading to better outcomes than the lenalidomide and dexamethasone alone. Importantly, I guess one note is they didn't directly compare the combination with dex to the combination without dex. So they didn't have daratumumab in that other group of patients with the dexamethasone. And for me, that would be the very definitive answer as to which of those two options is better. But I guess it is reassuring to know we can still get better remission times for patients by using the dara-len combination than len-dex. Another study for the older patient group is a study that I've actually been part of, but was presented by the chief investigator of the study, Gordon Cook, at the meeting. And this is a study called Fitness, where we looked at trying to ask the question whether we could use frailty scores that can assess patients' likelihood of experiencing side effects to really tailor treatment a bit more personally for patients and use those scores to determine what dose of each drug might be the most appropriate for a patient. And so in this study, patients were randomized between having standard dosing of drugs, so which would usually be considered the approved drug amount, or frailty adapted dosing, which would instead use a frailty scored approach to dose reduce for patients based on levels of frailty, with the idea that we would hope that by reducing the dosing, that patients might experience fewer side effects and therefore be able to stay on treatment for longer and have better outcomes in that way. We had 733 patients from all around the UK recruited into the study, and almost a third of patients were over 80 years old. So again, with the previous study, this really represents a large body of data in these older patients. Patients had to be newly diagnosed with myeloma and considered not suitable for a stem cell transplant by their doctor, and assessed as being either fit, unfit, or frail based on the international approach to frailty scoring in myeloma. And then patients were randomized, as you can see at the bottom. What we looked at first was something called the early treatment cessation, which is how quickly patients needed to stop treatment usually based on side effects. Surprisingly, we actually, in the overall outcome from the study that you can see on the left, didn't see a difference in the two approaches between how many patients needed to stop treatment early. What we did see was that there was some difference when we looked the specific groups. So in the group of patients in the intermediate group, otherwise called unfit in this scoring system, we actually found there was a difference between frailty adaptive dosing, shown here, and the reactive dosing shown here, but that wasn't consistently seen across all of the patients within the study. And we're trying to look into why that might be and therefore which patients might benefit the most. But what we did see across all of the patients in the study was that there was a benefit in terms of event-free survival and overall survival for patients, that these were both improved with the frailty adapted dosing. So taken all together, we interpret that this might be a beneficial way of delivering treatment to patients. We didn't see a significant difference in the safety profile between the two groups of patients, and we therefore concluded that frailty adapting dosing, although it didn't impact early treatment cessation in all patients, it was associated with improved event-free survival and overall survival, and so gives us some data to support this approach for patients going forward. So if we move into the relapsed myeloma space, I wanted to just highlight some of the abstracts that I thought were exciting about new drugs on the horizon to treat myeloma. So the first is a study of a drug called enobosarm, which is shown here and was given in combination with pomalidomide and dexamethasone. This is the very early phase clinical trial. So unlike the trials that I've presented so far, which are what we call phase 3 or later phase clinical trials, this is very much at the stage of trying to check that these drugs are these new agents, new possible drugs of the future are safe to deliver to patients, and what the right dose of these drugs are, especially in new combinations when you start to add them into other drugs. And so in this phase 1 trial, you can see that patients receive doses at different levels, as shown in the table in the bottom right. So we started with one dose of enobosarm and one dose of pomalidomide, and then we increased one and then increased both of them to look at those different dose levels and assess whether that led to different degrees of side effects for patients, and also look at how that impacted patients' myeloma. So this is an interesting drug that has a totally different way of working than any other drug we've used in myeloma before. And there's some evidence that it can both work on its own, but also that it might be able to work particularly well with pomalidomide and other drugs of the same family as pomalidomide. It's a tablet, which means that the enobosarm, pomalidomide, dexamethasone is an all-tablet combination. 40 patients were included in the analysis that was presented at ASH, and most had had 5 previous lines of therapy or had relapsed 4 times since their diagnosis and initial treatment. And actually, most of them had already had pomalidomide at some point and had progressed whilst having that treatment, which is termed refractory to that drug. And you can see the study approach in the table of dosing at the bottom. And this is just one snippet of the data that was presented, but really shows the responses that were seen in patients with this combination. You can see in this slightly complicated bar chart, but there are different doses summarized at the bottom, so of the enobosarm and of the pomalidomide. And then the response rate is summarized at the very bottom as a percentage. So you can see that with the lowest doses of both drugs, 56% of patients responded. With the slightly higher dose of POM, but no change in the enobosarm dose, 33% of patients responded. And then when both drugs were at the higher level, there were 75% of patients responded. But I should just point out, this is a relatively small number of patients. So overall, you can see the number of patients in each group shown in this graph as well. But I think it's exciting early data to show that there is some potential for response with this combination, even as I say, in patients who've had pomalidomide previously. In terms of side effects, there were more patients who had low platelets on the study than would be expected with the pomalidomide and dexamethasone on its own, but there didn't seem to be any other additional significant toxicities. It didn't seem to add too much else. And platelets are the cells in our blood that help blood to clot, and we didn't see much bleeding in patients with the study. It was rare, and when it did occur, it wasn't severe. Other side effects that we also see when we use pomalidomide and dexamethasone alone included fatigue or tiredness, neutropenia, which means low white blood cell count, and infections. And so the authors overall concluded that the highest efficacy was seen at the doses of enobidrib at 35 milligrams and 4 milligrams of pomalidomide, and that at that level, 75% of patients had a response. But there was activity seen across all of the dose levels. So for me, it's exciting to have a treatment that has a totally new mechanism of action, and these initial results in this combination look promising. And the fact that it's a tablet that can be taken at home is also a positive in comparison to some of the other treatments I'm going to come on and talk about, which require a little bit more intensive support in hospital when we start some of them. So for me, that was exciting data to see. So I'm going to come on to one of those other new drugs now, and this is a drug called anitocaptogene autoleucel, and this was studied in a trial called Imagine-1. And this is a CAR T cell therapy. So this may be something familiar to you, but where we take T cells from patients and then engineer those T cells to be able to directly target a patient's myeloma, and then give back the T cells once they've been engineered back to a patient, and then those T cells go off and target patient's myeloma. I've included these two diagrams. They're both a bit complex, but really just to take the message that some of these previous CAR Ts look more like this picture on the left, and the new CAR T that was presented in this study is just has a slightly smaller engineered molecule that gets presented on the T cell. So it's just a different way of changing that T cell to target the patient myeloma cells. What the authors presented in this study was that they have so far, I think, recruited almost 130 patients, of whom almost 120 have had CAR T cells infused. And what they reported was 86 patients who have so far been accessible for a response who have had CAR Ts. Most of the patients, like the study I just presented, had had lots of previous treatments. So they'd had a median, or an average of 4 prior lines of therapy. That means they've relapsed 3 times since their diagnosis and initial treatment. And most were refractory to most of the commonly used drugs for myeloma treatment. All the patients were planned to receive what had previously been determined to be the safe dose of CAR Ts in a previous study shown here. And they had the usual approach to delivery of CAR T, which is usually done in a hospital, requires something called lymphodepleting chemotherapy, which means some treatment that's given before the CAR Ts are returned to the patient. And then patients are monitored and assessed in the hospital for a short while before being discharged. These are the a snippet of the results that were presented. This is, as I say, for 86 patients that were accessible. And you can see that really impressively, almost every single patient responded to treatment that was given. So you can see 97% of patients had a response. And for lots of patients, that was a deep response. So shown here, what the CR in this diagram means complete response. So a really excellent response to treatment. Summarized in the table, you can see the percentage of patients who hadn't progressed at each of these time points with the drug. So at 6 months after receiving the drug, 93% of patients still had not progressed. And at a year, that's almost still nearly 80% of patients. And for patients who've had so much previous treatment, have unfortunately had their myeloma progress after most of our commonly used drugs, this represents good periods of remission and good periods of survival. In terms of side effects, one of the things that the authors reported was that most patients didn't have particularly severe side effects from the initial administration of the CAR T cells. So when we first give CAR T cells, this can be associated with an inflammation of the immune system, which is called cytokine release syndrome, and makes patients feel unwell with a fever, or sometimes have a low blood pressure or need additional support. And they also didn't see much in the way of neurological toxicity, which has been seen with some of the other CAR T cells. And so they really presented this as being something that The follow-up was long enough to have been expected to see some of those side effects if they were going to occur, but they haven't seen those yet, which is reassuring for the use of this CAR T approach. They did see infections, low blood counts, fatigue, nausea, and headaches with this, which are common side effects that we see with CAR T cell approaches. But overall, they concluded that most patients did respond to treatment with some very deep responses, and there was a low or even very low or non-existent incidence of some of these side effects we see with CAR Ts. So for me, we obviously need longer follow-up to know how this compares to some of the other CAR T cell therapies that are now available in some parts of Europe and in the US. But the initial idea that maybe these lack some of the side effects that we see with other CAR T cells today is very enticing and promising, and we'll look for more data to see whether that pans out in future studies. I've summarized a few other studies that on this slide, which I'm going to run out of time to go into much detail, but I just wanted to mention some of the other data for relapsed refractory myeloma. So we saw data for a new bispecific antibody target, so targeting something different on the surface of the myeloma cell than some of the commonly used approaches, which target something called BCMA. This drug called cifostamab targets a protein called FcRH5 on the surface of myeloma cells, and they presented data for this. There was also a study looking at a tri-specific antibody, so rather than targeting just one protein on the myeloma cell surface, this approach targets two proteins as well as drawing in the T cells of the immune system. And then there was also interesting data about a drug called mezigdomide, which is a cousin of drugs like lenalidomide and pomalidomide that you might be more familiar with. Mezigdomide alone has shown good responses in patients with relapsed disease. And what was presented at ASH was a number of other combinations, so putting mezigdomide with a number of other drugs, some which we commonly use, some which are also new, and showing that up to around 3/4 of patients did respond to some of these combinations. I'm going to move on and talk a little bit about amyloid. And I think for me, one of the interesting bits of data presented at ASH about amyloid was the overall survival data from a trial called Andromeda. This was a study for newly diagnosed patients with amyloidosis, and patients were randomized between having Velcade, cyclophosphamide, and dexamethasone on its own as initial treatment, or adding in daratumumab into that combination. Daratumumab is an anti-CD38 antibody, as we mentioned a bit earlier. There were 388 patients included in this study. I'm sorry, that's a carryover from my previous slide, so ignore that comment about patient age. This is the result of that study that was presented at ASH, and you can see that at 5 years after starting treatment, 76% of patients with the addition of daratumumab into their initial treatment remained alive, compared to 65% of patients receiving treatment without the daratumumab. So adding daratumumab seemed to improve overall survival for newly diagnosed patients, not just progression, not just organ function, which we had seen already from this study, but actually overall survival for patients as well, which I think is really important data to see. There was also other data for amyloid, looking at a CAR T cell approach with an academically generated CAR T in the study at the top of this slide, another study looking at the use of a drug called venetoclax, which we have seen is more effective in myeloma patients with a particular genetic change that is actually more common in patients with amyloidosis. And so this study looked at 36 patients treated with venetoclax and looked specifically at their responses with this genetic change. And then at the bottom, the study looking at the combination of isatuximab, pomalidomide, and dexamethasone for patients who'd either had relapse of their amyloid or hadn't had as deep a response as was hoped for with their initial treatment. And with this combination in the 41 patients included, 80% of patients achieved a very good partial hematologic response or better, and they showed that those responses were actually very quick, which is really important for patients with amyloid. We're trying to clear away the abnormal cells that are driving the abnormal protein deposition. So quick responses are really, really helpful in this setting. And then just to end, I just wanted to show some data about smoldering myeloma. So this is a condition that can sometimes be detected before patients are diagnosed with myeloma, and we think usually does exist before myeloma. Patients with smoldering myeloma do not currently receive treatment, at least in most of Europe. And patients are monitored, and we're watching out for signs or any indication that treatment should be started at the point at which it looks like the disease is progressing to myeloma itself. This study aimed to understand whether we could give the anti-CD38 antibody daratumumab to try and delay that progression to myeloma. So comparing the use of daratumumab, you can see at the bottom, to just close observation by a specialist as opposed to any treatment. And the daratumumab was given weekly for 8 weeks, and then alternate weekly for 16 weeks, and then monthly for 3 years. So patients had 3 years of treatment overall, but for most of that time, it was given once a month as opposed to more often. In this trial, 390 patients were included, and all had what is called high-risk smoldering myeloma, which means the end of the spectrum of patients with smoldering myeloma thought at a slightly higher risk of progressing to myeloma itself. What you can see here is the overall result in terms of progressing to myeloma. So you can see that at 5 years, 63% of patients receiving the daratumumab had not progressed to myeloma, whereas for those who had active monitoring, 41% of patients had not progressed to myeloma. So you can see that there's a difference between how many patients have progressed. What perhaps is more important in terms of the longer term outcomes is the overall survival of all of those patients, and that's shown here. And you can see that at 5 years, 93% of patients who were randomized to receive daratumumab were alive, compared to 87% of patients receiving the active monitoring or the close monitoring from a specialist approach. And so you can see that there's a difference there of 6% of patients at that time point. The authors did report that patients receiving the daratumumab were more likely to have serious infections, including pneumonia. So there were 16% of patients receiving daratumumab who had a serious infection, compared to 5% of patients who were observed and followed up. But the authors nevertheless showed that there was that the use of daratumumab was associated with a lower rate of progression to myeloma and better survival compared to active monitoring. My take on this is slightly complicated. We could discuss this for a long time. Perhaps there'll be some questions and we can have some more time to discuss it at the end. The approach, the way the study was done, is very good. There were lots of patients in the study. They were fairly divided between the two groups and monitored for follow-up. There is what we're trying to do when we prevent progression to myeloma is prevent harm to patients. And actually, even in the patients who were observed, there were very low rates of harm to patients because the progression to myeloma was picked up fairly quickly by the monitoring doctors. And so for me, it's a balance between treating patients earlier than usual against trying to prevent side effects for patients who wouldn't otherwise be treated versus trying to prevent damage from the myeloma. So for me, if it becomes available for us to use in the UK or elsewhere in Europe, then for some it will be a very personal choice for patients and really a discussion about what the approach that they want to take is based on our experience of treating this condition in the past, as well as the data from this and other studies looking at smoldering myeloma. I've included a few slides of a study called Nutrivention, which was a study for patients with MGUS and smoldering myeloma, because this is a question I'm often asked in the clinic. Is there anything I can eat or take that will change what happens to my MGUS or smoldering myeloma over time? And this is a study all credit to the authors for trying to perform their study and really try to provide evidence of whether the answer to that is yes or no. As a spoiler alert, that I'm not sure this study does tell us that answer yet, but it does help us to move in the right direction. At the moment, the authors have looked at 20 patients, all of whom had MGUS or smoldering myeloma and a body mass index of more than 25, so slightly over the recommended spectrum. And they also performed some laboratory studies in mouse models of myeloma. And what they did was ask patients to eat a high fiber plant-based diet for 12 weeks and also provided health coaching to the patients to try and stick to that diet for 24 weeks. And then they followed up patients for a year. Importantly, they didn't restrict the calories patients were taking in. It was all about the high fiber plant-based dietary intervention. Just to say, this study was aimed at assessing whether this was feasible, whether if this was suggested to a group of patients, it was feasible for patients to stick to this approach of altering what they eat. The diagram at the top of this study just shows that what I've mentioned in a picture format. So you can see the duration of time that patients were taking the plant-based diet and the duration they had nutrition coaching for. Overall, the results showed that the adherence of patients to the diet was very good. And you can see that summarized in this plot over here. So at baseline, a relatively low percentage of patients were following a high fiber plant-based diet. And then after being provided with the relevant information and approach to doing this, a large number of patients did follow it. You can see that over time that seemed to fall off. So there were fewer patients following it at a year, but this is still many more patients than were following this kind of dietary approach at the beginning of the study. They found that there was a reduction in body mass index for patients, and this did seem to be sustained across the year. And they also reported an improved global health status quality of life measure for patients within the study as well. Importantly or interestingly, I think in some of the experiments that they performed in mice, the time to progression to myeloma was made longer in the group that were fed with the high fiber diet. But that was a study where they could treat two different groups of mice differently and look at the comparison. But in the patient aspect of this study, that hasn't yet been done. They treated all the patients within this study, received the diet, and they were looking at whether patients were able to remain on that diet or not. Importantly, patients did report, improved quality of life and reported finding it easy or very easy or somewhat easy to follow the diet over time. And so the authors concluded it was possible to stick to the diet, and they also provided some data that they would argue supports the possible beneficial role of using a high fiber plant-based diet for patients. So again, for me, there's lots to discuss in this study, so perhaps it will pique somebody's interest to talk about further. For me, the data that they showed in the mouse models is very encouraging, but it's hard to know how possible that will be to replicate in larger numbers of patients. But all credit to the authors, they are doing that. So this is a very small study, just looking to check that it's possible for patients to adhere to this kind of diet, and they are planning, or I think have already got underway, a randomized study to compare what happens to a group of patients who do follow this approach and those who don't, which is really what we need to understand whether this is really going to make a difference to progression to myeloma. I just wanted to highlight a few other studies looking at smoldering myeloma, not least a study at the top from one of the MPE partner organisations, Myeloma UK, looking at the psychological effect and perspective of patients for the burden of living with a diagnosis of MGUS or smoldering myeloma. There were also many studies looking at other treatment approaches for these precursor conditions. So again, conditions that we, at least in most of Europe, wouldn't currently consider treatment to be standard for. There are lots of studies looking at different approaches to treatment that are kind of trying to understand whether that is the right approach. But then also very interestingly was a report from a Greek group who had looked at 427 patients with smoldering myeloma and actually found that the risk of progression if advanced imaging techniques and other approaches are used to monitoring patients, the actual progression to myeloma didn't seem to cause patient harm in as high a proportion as we've perhaps seen in studies in the past. So perhaps maybe not only our advances in treatment, but our advances in monitoring and diagnostic tests is changing what we should consider doing for patients with smoldering myeloma, because if we're able to prevent that harm, that's really what we're aiming to do. And if that can be done without treatment, then obviously that might be beneficial for patients as well. So for me, that was also an interesting study. So hopefully I've shown you data that shows that the outcomes and approaches for treating myeloma are improving, particularly for newly diagnosed patients. And that's true now of patients at all ages. Really exciting to see data for patients in the older age group, as that is actually what the most common age group for patients being diagnosed with myeloma. Interesting to see trials addressing some of these questions that are of key importance to patients, and we're often asked about. So can I stop dexamethasone? Is there anything I can eat or do differently to alter my myeloma? Lots of these patient priorities are really driving the research that we're seeing now being reported. And then for me, there are some exciting novel treatments, both in terms of immunotherapies and also other novel tablet therapies that are really on the horizon, and we hope to see more information about in the coming years.
I'd like to move to the question and answer part of this webinar, and I see that we already have a few questions in the Q&A window. So I'll try to go chronologically from the beginning of your talk to the end of your talk. Um, so there are two questions around the quadruplet regimens. The first one is about the study you presented with isatuximab. Could you tell us how it's comparing with similar quadruplets, like for example with daratumumab?
Yeah, so it's an excellent question. So both isatuximab and daratumumab are targeting the same protein on the surface of a myeloma cell. So they're both what we call naked antibodies. They're an antibody that targets the cell surface and acts like a flag to trigger the immune system to recognize that cell as a myeloma cell and hopefully destroy it, and also has some direct activity on destroying the myeloma cells as well. So there have been lots of studies, and I understand where the question is coming from. There have been several different studies looking at adding both of these drugs into slightly different combinations for frontline therapy. I guess for me, my takeaway is it seems from all of the studies that adding in that anti-CD38 antibody early in the treatment of myeloma seems to be very beneficial. And I think this study really just adds to that overall data that is a good approach for patients.
Okay, but we don't know if one is better than another.
So we don't have any data to suggest that one is better than the other, no.
Okay, and there's a second very interesting question about quadruplets. So, if one gets multiple drugs at frontline, um, do you think it's leading to any problem in what will be available down the line for patients?
So it's a really good question. It's about whether if you give all of these drugs, you sort of lead to more resistance to treatments. But I don't think that is the case, that is not how I would see this approach. And I guess part of the reason for saying that is that we don't usually continue all of the drugs in the longer term. So we're giving the quadruplets for, as was done in this study, in the study that I talked about, before autologous stem cell transplant, and then usually one or two drugs after the autologous stem cell transplant. And so, and again, those drugs may be not indefinitely. So we're looking at seeing more and more studies coming out now looking at not giving all of those drugs at least indefinitely, maybe giving one, but maybe stopping some of them. So, and that means that at the point at which the myeloma relapses or comes back, that it won't be progressing through all of those drugs, and those therefore some of those drugs that may have been given, hopefully many years previously, could still be effective at the point of relapse.
Okay, that's good to know. We have a question around maintenance and the latest updates we have on maintenance therapy. Is it still based mainly on lenalidomide? And if so, what is considered as the most effective maintenance therapy? And would combining it with other immunotherapy agents, and the example cited here is daratumumab, would offer um, better options?
Yeah, so an excellent question. I think that the standard approach to maintenance in most parts of the world is still lenalidomide on its own. There's lots of data to support the use of lenalidomide compared to no maintenance, for example, after an autologous stem cell transplant. There is some data to show that adding daratumumab into the lenalidomide might be helpful, but it's tricky because some of those studies were done in patients who hadn't had daratumumab or another anti-CD38 antibody in their initial combination. And so it's hard to know for sure whether everybody who's had an anti-CD38 antibody in their initial treatment needs to also have it as part of their maintenance therapy. And actually, the study that I presented from the German group is also asking that question, but hasn't got enough data, enough follow-up to be able to tell us the answer yet. So they did look at randomizing patients for the maintenance part between having just lenalidomide or having the isatuximab anti-CD38 antibody as well as lenalidomide. And so that will really give us very clear information about that, because some of the other studies, whilst they sort of suggest that maybe having an anti-CD38 antibody as well could be helpful, is slightly less clear because of that previous treatment. The only exception to that, I would just want to add, it would be for patients who have what we would define as genetically high risk myeloma at the point of their myeloma diagnosis, where there is some evidence that continuing combinations of treatments for longer is likely to help try to overcome some of that high risk nature of the disease. But that wouldn't be for everybody. That would be for patients with that high risk group.
Thank you. We have a few questions about the new treatments you told us about. So the first one is about the mechanisms of action of inobrolib. So could you tell us how this drug works and what drug class it belongs to?
I'm going to try. So it's an epigenetic modifying drug. That means that it alters the way in which we think that the DNA code in a cell is read and then translated into making proteins. So it's a different mechanism to most of the drugs that we're used to talking about. It is a different approach, but it alters the way in which the cell instructions are translated into the way the cell works. And therefore can alter some of the key proteins that help to keep myeloma cells alive, and reduces the expression of those proteins, which can, especially in combination with the pomalidomide, then lead to cell death. I'm not sure if that's a very clear explanation, but I will
Thank
do my
you.
best.
No, thank you, Dr. Pawlyn. The second drug we have a question about is mezigdomide. So could you tell
Mm.
us if it's approved in Europe or if it's still an investigational drug or when one should be expect to see it on the market?
Yeah, so I guess just to be clear, a lot of the drugs that I talked about today, especially in that section, are not yet approved. Neither are approved nor reimbursed in lots of parts of the world, but not approved. So mezigdomide is one. It is not yet approved. It is still in ongoing clinical trials. So we've seen clinical trials with mezigdomide and patients with very relapsed refractory disease who've had many previous lines of treatment. And there are currently ongoing trials looking at it in patients who've maybe had only one or two prior lines of treatment. And so once we've accumulated a bit more data, that's the point at which hopefully it would then be approved and then become available after that.
Okay, thank you. I have two questions around CAR T cell therapy, and the first one is about the anito cell, the product you presented. The question is it a CAR T product that can be manufactured more rapidly, thereby reducing the need for bridging therapy, or what's the difference with other existing and even approved treatments?
That's an excellent question, and I can't give you an instant answer because I can't remember the exact manufacturing time for that agent. That's not a trial that I've got personal experience of, so I can't remember, is the honest answer. So whatever I tell you might be wrong. But I believe that I definitely know that within the study there was a bridging therapy portion. So there was an ability to give bridging therapy to patients. That suggests to me it may not have been super short because but there would have been enough gap
Mhm.
to give bridging therapy, but I can't tell you the exact time frames.
I understand. Thank you. The second question on CAR T is about whether there were any studies presented at ASH that addressed the issue of infections after CAR T cell therapy, but also after bispecific antibody treatments.
Yeah, so there's a lot of increasing information, I guess, about infections after both of those treatments, so both bispecific antibodies and CAR T. So we know that the BCMA targeting bispecific antibodies and CAR Ts both are associated with an increased risk of infection, and that's because not only are they very effective at getting rid of the myeloma cell, they're also very good at unfortunately getting rid of some of the normal immune cells that help us to fight infection. And we're seeing both real world cohort data coming out from lots of different places that have access to these drugs now. And also, particularly at ASH, there was a study looking at the use of intravenous immunoglobulin to prevent infections. I think that's something we now feel much more strongly about, making sure patients have at the point if their immunity drops on the treatment, that we start the IVIG quickly. And this is a way to replace some of the usual antibodies that you would normally be able to generate, but are not able to do because of the loss of some of those immune cells.
Thank you. Um, we have a few questions around AL amyloidosis. The first one is, could you tell us what role MRD plays in AL amyloidosis and how it can be linked to the worsening or the improvement of cardiac symptoms, for example, or other organ responses?
So when we're treating amyloid, what we're trying to do is get rid of as many cells as possible that are generating the protein that can misfold and cause damage to the organs like the heart or the kidneys. And so achieving as deep a possible response so that there is as little of that protein being produced is what we're really aiming for. And minimal residual disease comes into that. That is a measure of how many leftover cells there might be. There's perhaps less data about MRD levels than there is in myeloma, but the assumption is that the deeper the response you get, the likelihood is that that will both prevent accumulation of additional protein and also lead to longer periods of remission.
Okay, thank you. And speaking about MRD, there's another question about the role of mass spec in MRD assessment. Do you think mass spec analysis on whole blood could improve how often MRD can be assessed?
I really hope so, I guess is the answer. So just for anybody who's not familiar, so mass spec analysis of the blood is a different way of trying to get a very sensitive assessment of how well a patient has responded to myeloma treatment. So rather than doing bone marrow to look and see whether there are any leftover cells in the bone marrow, a blood sample can be taken, and then we're trying to detect very low levels of what you would commonly test as a paraprotein or a serum free light chain test. And there are some studies looking at how they interact and whether you could replace one with another. The challenge is that often doing both provides additional information. So that's always a bit of a challenge because then it it's hard to get away from trying to do bone marrows occasionally. But I think how I see it going, I guess, is that we would potentially be able to maybe do bone marrows at only a few time points and then do blood monitoring in between to try and spot any changes in these with these very sensitive mass spec analyses. Whether it completely gets rid of bone marrows, I think we would all hope, and I know most of my patients would hope, but not quite yet, I guess, is where we're at.
I understand. Thank you. We have one last question in the Q&A, so I'll try to address that as well. We have an attendee interested in hearing your opinion on lenalidomide maintenance. What is the belief at the moment? Should we continue until relapse, or is there an argument to stop after a certain amount of time to allow for treatment-free period of times?
Yeah, so it's a really good question. I think there are lots of people trying to answer this question in slightly different ways. We've tried to look at this in data from the UK Myeloma 11 trial, where one group of patients had lenalidomide maintenance and one group had none. But that wasn't the same as looking exactly at if you had it for X amount of time, what happens if you then stopped in half of patients and not in the others. So it's a complicated question. There are a number of trials that have tried to look at if you are on lenalidomide maintenance and you can show a really deep level of response, so an MRD negative response, especially if that is sustained over a period of time, that stopping lenalidomide maintenance in those patients seems to be associated with a very low rate of the myeloma then progressing. In some of those studies, patients will then restart lenalidomide at the earliest sign of any change in their disease. For me, that would probably be the most likely approach that we'll move towards. But in order to do that, you have to monitor using the MRD tests, which we currently do by bone marrow tests quite regularly, to be able to see those changes, to be able to see that depth of response and then any changes going forward. And obviously that comes with its own challenges for both for patients in terms of the discomfort of having a bone marrow, but also in a lot of parts of Europe, especially bone marrow MRD or any MRD assessment is not being done that routinely. And so we're not having all of those monitoring in place already. And so in the absence of that monitoring and being able to tell that that depth of response is there, our approach is still to continue lenalidomide maintenance until disease progression. But as we get some of these monitoring some of this monitoring better in place, then I think we can move away from that, but probably not for all patients. So for patients who are MRD positive, for example, or perhaps have genetically high-risk disease, we wouldn't want to stop.
Thank you. Well, I think this is the end of our webinar. I still have many questions from my point of view, but you gave us a very comprehensive view of what was presented at ASH. So thank you so much for that. And I will leave you the floor for your final words. But on behalf of MPE and from all our attendees, many thanks, Dr. Pawlyn, for being there with us to share your highlights and to answer our questions. So I will leave you the floor for your final words with the audience. And if you want to share what we should expect in the year or the years to come in terms of what will be coming out of ongoing research. Thank you so much.
Thank you very much. Thank you very much for inviting me, and to everyone who's attended to listen this afternoon. Yeah, I think it's lots more exciting data, some of which will solidify some of the things that we've seen early data for that I've talked about today, and others of which will hopefully present new and exciting approaches, both from the immunotherapy space as well as other approaches to treatment. And yeah, looking forward to seeing that coming out over the next year.
Thank you and happy holiday, everyone.